a randomized trial of colchicine for acute pericarditis. Colchicine has been used for centuries to treat and prevent gout attacks. More recently, it has been recommended to treat and prevent serosities in patients with familial Mediterranean fever and recurrent pericarditis. ICAP. This study, called the Investigation of Colchicine for Acute Pericarditis, was a randomized, double-blind, placebo-controlled, multi-center trial designed to evaluate the efficacy and safety of colchicine to treat a first attack for acute pericarditis and to prevent recurrence.
Hi, I'm Dr. Andy Thompson, and I'm a rheumatologist. Today, I'm going to talk about colchicine for the treatment and prevention of gout. You can visit our website, www.rheuminfo.com, and print off one of our colchicine picto pamphlets to follow along with this video. Colchicine is also known as Colchris. Now, colchicine is a medication used to treat and prevent attacks of gout. It is taken once to twice daily. Your doctor will discuss the dose. Now, there are a couple of things you need to do when taking colchicine. First, when you start colchicine, it's important to have occasional blood tests to make sure the medicine isn't affecting your blood counts. You should also watch how much alcohol you drink, as this can flare your gout. Now, the most common side effect of colchicine is diarrhea. The diarrhea can improve by reducing the dose. Colchicine can also upset the stomach with nausea and vomiting. Now, when used for long periods of time, colchicine can affect the muscles. Let your doctor know if you have muscle pain or weakness while taking colchicine. Colchicine has not been studied in pregnancy. Let your doctor know if you're planning to get pregnant or if you're breastfeeding. Now, if you're taking colchicine, you should call your doctor if you feel sick or want to stop, if you're concerned about any side effects, or if you've stopped or want to stop the medication for any reason at all. Now, for colchicine, there are a few other specific reasons to call your doctor. If you develop severe diarrhea, if you develop new muscle pain or weakness, or if you're pregnant or planning to get pregnant. I hope you found this video to be useful. For more information, please refer to our website at www.rheuminfo.com. I'm Dr. Ignazio from the cardiology department of the Maria Vittoria Hospital at the University of Turin, Italy. My presentation is on current therapeutic option in recurrent pericarditis with a special focus on colchicine. We know the most common and troublesome complication of pericarditis affecting 1/3 to 50% of patients with the pericarditis, and colchicine has been shown to be a safe infectious tool added on top of standard anti-inflammatory therapy, including aspirin or ibuprofen or corticosteroids, to halve the risk of recurrent system follow-up. Not only, but colchicine is also able to fasten the response to conventional anti-inflammatory therapy and to improve the remission rate at 1 week. So I'm presenting a systematic review on all the randomized controlled clinical trials that have been published, either for acute pericarditis, that is the COPE trial and the ICAP trial, and also for recurrent pericarditis, including the CORE trial, the CORE1 trial, and the CORE2 trials. And in all the studies, what we are learning from these trials is that, considering that the most common side effect of colchicine is gastrointestinal intolerance occurring in about 8 to 10% of patients, it is important in order to improve the patient compliance to avoid the loading doses and also to use well-digested doses. So,
Eligibility criteria. The study was conducted at 5 general hospitals in northern Italy. Consecutive patients who were 18 years of age or older with the first episode of acute pericarditis, idiopathic viral after cardiac injury, or associated with connective tissue disease were eligible for enrollment. What is the exclusion criteria? Patients with any of the following criteria were not eligible to participate in the trial: tuberculosis, neoplastic purulent pericarditis, severe liver disease, blood dyscrasia, inflammatory bowel disease. Randomization and study drug administration. Patients were randomly assigned to receive colchicine or placebo in 1:1 ratio with the use of a central computer-based automated sequence. Colchicine was administered at a dose of 0.5 to 1.0 milligrams daily for 3 months. Follow-up and outcomes. Followed all patients for at least 18 months after enrollment. Regular visits were planned at 1 week, 1 month, 3 months, 6 months, 12 months, and vary every 6 months thereafter until the end of the study. Testing at each visit includes blood chemical analysis, complete blood count, electrocardiogram, echocardiogram.
In this visit, I'll talk about the complete blood count, a series of blood tests. The complete blood count, the CBC, assesses diseases that affect red blood cells. The red blood cells carry oxygen to all the cells of the body. Anemia is when there are fewer than normal red blood cells. Polycythemia is the problem of more than a normal amount of red blood cells present. The CBC assesses diseases that affect the white blood cells. The white blood cells fight infections in the body. Leukopenia means fewer than normal number of white blood cells. Leukocytosis, an increased white count, means more than the normal amount of white blood cells. An echocardiogram is also known as an echo or a sonogram or an ultrasound of the heart, and it uses ultrasound technology to look at the size and squeeze of the hearts.
Results. All patients who tolerate treatment with colchicine or placebo discontinued this therapy at 3 months as planned. No open-label colchicine was administered after the end of the study period. No patient was lost to follow-up, and all patients were analyzed for outcomes according to the original study group assignments.
My name is Dr. Alan Klein from the Cleveland Clinic. I direct the Pericardial Center at the Cleveland Clinic and the Director of Imaging Research. That's the first step. What are the markers of inflammation? The first one would be the SED rate. The second would be the C-reactive protein, or the ultrasensitive C-reactive protein. Usually with active pericarditis, these markers are elevated. So my first-line therapy is really something benign such as the NSAIDs. I like ibuprofen at a large dose with a wide range.